Okay, we are still busy with the Mother Baby Friendly Initiative series. I'm still Anna Nolte, and we are at lesson 4 of session 4, which is about newborn problems. So in this lesson, we're going to talk about the breastfeeding problems from the neonate side. The problems I almost want to say that the neonate cause in breastfeeding. First problem that we are going to discuss here is what we call refusal of breastfeeding, or the so-called nursing strike. And in this case, it was a baby or a toddler, it doesn't matter what age, that has been breastfeeding well and suddenly just refused to nurse. And that's why it's been called a nursing strike. And there are many possible causes for this. And we will come to it again. The most important thing is to do a really good assessment of what's going on in order to find out what the real problem in this case is. It might happen that the baby's been separated or was separated from the mother after delivery, sometime after breastfeeding has now is been established, or it can even be later on when the mother starts working again, and that might cause the baby to just refuse the breast. It's a more psychological thing than anything else. Or the baby had been fed from a bottle or had sucked a pacifier or a dummy, and that caused what we have talked about, nipple confusion. Or there's poor latching, the baby is not latching very well, and there's also poor technique regarding the positioning of the baby and the latching of the baby. For example, pressure on the back of the baby's head and things like that, which we have discussed in the previous session. And that makes then that the baby obviously does not get enough milk. He starts drinking, he starts sucking, he doesn't get enough milk, and then he gets angry and refuses, and then gradually the breastfeeding becomes more unpleasant for him, and he starts refusing the breastfeeding. Or it might be a delay in the milk coming in the let down reflex, which also makes that the baby starts sucking, and then suddenly there's not enough milk, and then let go of the breast. Or there's breast engorgement, or just other problems. Another problem is even oversupply of milk. There's too much milk, so the baby starts sucking, and then the next minute it comes off the breast and is choking or crying with milk spraying all over. And that's been also one of the possible reasons for refusal of breastfeeding. We will talk about oversupply of breast milk in detail also in the next session when we are talking about other breastfeeding problems. Excuse me, still more problems might be a blocked nose. The baby also starts suckling, and then he stops to breathe, because babies can't breathe through the nose is blocked, and he can't breathe because he's sucking with his mouth. Or there might be a sore mouth, candida infection thrush, or teething in the older baby. Also, the baby starts suckling a few times, and then he stop and cry, or may refuse altogether. Or sometimes the baby refuses only one breast, but and not the other. And this is also a problem that affects only one side of the breast, and one needs to also look properly at what the possible problem of this might be. Now, how should this problem be managed? Now, again, as I've said previously, I think very, very important is the proper assessment of all breastfeeding aspects to see what the main problem here is. And one can use the instrument that I taught you about the previous time, to make a proper assessment of the mother, the breasts, the baby, the behavior of the baby, latching, etc. And then, depending on what the problem is, it should then be treated or remove the cause if the cause is removable. And the very important thing here in this problem is to help the mother and the baby to enjoy breastfeeding again, because it becomes such a negative experience for both of them that and the cycle is just getting worse, that they don't enjoy it at all. So first of all, before we start treating or removing the specific cause, very important in the general measures is to help the mother to relax and to concentrate on making breastfeeding a pleasant experience. Because we all know and have heard it now several times, that when the mother is not relaxed and whether she's anxious or experience stress, like in this case, obviously the lay down reflex will be influenced by that. The baby will also feel a tension, and that will make that breastfeeding won't work. So to reverse that again, the mother should really be taught and helped to relax and to concentrate to make breastfeeding pleasant. It also, the baby is crying, and as we have said now many times, the baby's upset. So he won't. We all know that babies don't latch properly to the breast when they are upset. So it is very important to stop and comfort the baby first of all before even trying to latch the baby on again. By cuddling, by stroking, by doing skin to skin contact. We have said previously that skin to skin contact is a very good measure to help with babies that's not happy and babies that's been stressed, because the closeness makes them to relax, and that becomes then a more positive experience. What also might work is if the baby is less than a month old, even a little bit older than a month can still work, is by how the mother try hold him and feeding him skin to skin contact, and a reclining, leaning in a back position where the baby is lying on a tummy, skin to skin, and he comes to the breast and he latches himself, and that hopefully might solve the problem. In the meanwhile, it's very important that the mother should make sure that the baby still gets enough milk, because now when he screams and he doesn't want to take the breast, obviously he's not going to get enough milk. And also very important, except for the fact that the baby gets enough milk, is to also to keep her milk supply flowing, to keep her milk supply going. So it might help to express milk after she tried to put the baby on to the breast again and it didn't work. She can express breast milk and then give it to the baby in a form by a cup or a spoon or a dropper or a syringe. And here it's really very important not to give the feeding by with a bottle, because here is now definitely a place where nipple preference might play a role, because the baby just prefer the bottle, which is a much more pleasant experience than sucking on the breast. Now, what is also very important here, because she wants to keep a milk supply flowing and going, it's very important that while the baby is refusing the breast, that she still extract milk as often as the baby has been nursing. So if the baby is, for example, nursing 8 times a day, she should try and express milk 8 times a day. Obviously, she should always first try to get the baby to latch the baby to the breast, and if that doesn't help, to express the milk from there. And here it really depends on what the mother's choices. She can do hand expression, and because this is hopefully only a temporary problem, hand expression might work very well here. Or she can buy a breast pump and do some pumping. Smaller pumps are more would be a better choice here, because it's, as I'm saying, hopefully going to be a temporary problem. Sorry, not only does she keep her breasts, the milk supply going, but it also saves her from potential clogged ducts and mastitis, which makes the problem just a little bit bigger and worse than what it is. And then now these all were general measures that we have applied to help the situation and to help to solve the problem. And then, as we've said, we should do a proper assessment and find the problem, and then treat the problem. And these are all possible problems. If the baby had been unable to attach and suckle, and this is a sudden thing, the mother might also contact the health worker to help her to just assess, or a doctor to just assess whether this is a general illness of the baby or whether there are any other problems. If there are, for example, general infections, it can be treated with the appropriate antimicrobials or other therapy depending on what the real problem is. And then, as we've said, in the meanwhile, while the baby is being treated, the mother can express her breast milk and feed the baby with a cup or a tube. Or if pain is the possible reason why the baby suddenly screams and cry, I think the same would apply, that she should contact the health worker and that the health worker should assess the baby and see where the pain is coming from. And the mother can then also be helped to hold the baby without pressing on a painful place, for example. Often the mother is on permanent or regular sedation or a type of sedation medication, and then if that might be the problem causing the baby to be sedated and not properly latching, it would be good to find the alternative for this medication for the mother in order to help the baby to breastfeed. Or in the beginning of breastfeeding, we have talked about the possibility that pethidine caused the baby to be sedated for quite a while after the birth of the baby. And in this case, the mother must just be supported till the drug's been cleared out of the baby's body in about 2 to 3 days. So she must just being helped to try and latch the baby, to try and get the baby awake as much as possible. If it's due to some or other breastfeeding difficulty, if we have found in our assessment that this is due to some or other breastfeeding difficulty, it's very important to find and discuss the reason of the difficulty with the mother. For example, it's not proper latching, or the position of the baby is not good, or whatever. So it's very important to find the reason together with the mother and then to discuss it with the mother. And also, if this is a temporary problem, for example, engorgement or sore nipples, or things like that, it might also help to teach the mother to express her milk in the meanwhile and give the baby other alternative. And then also help her with the technique, help her to latch the baby and give her support, and then also obviously help her to build up a milk supply in the meanwhile. And here, as we have said also many more times, and will say many more times, confidence and building up confidence is very important. Oversupply, we will come, as I've said, we will talk about oversupply in detail next time when we are doing all the breastfeeding problems, but it might help if the mother expresses a little bit of her milk before she offers the baby the breast, just to make the help for this initial milk that flows so fast. She can also slow the flow of the milk by holding her breast with a kind of a tight scissor hold to almost hold the milk a little bit back. She can also breastfeed by laying on her back, and gravity helps then also for the milk to flow a little bit slower. And what you can also do is to let the baby suckle only on one breast at a feed, instead of twice getting this oversupply of milk. He first empties the one breast, and that will also enable him to get hind milk as well as fore milk, and not only fore milk in both breasts. If the problem is thrush, then it should be treated. It can be treated with Jensen Barlot or nystatin or whatever medication is being prescribed. If the problem is teething, the mother has to almost kind of work through this. So the mother needs to be encouraged and to be supported, to be patient, and to keep offering the baby the breast. And hopefully that will also be, as I've said, a temporary problem, and the problem will be hopefully solved soon. Blocked nose suggests short feeds more often than usual, so that the baby, while his nose is partially or blocked, that he can have a few good sucks before the nose becomes really blocked. A few saline drops in each nose might help, and it also often helps to just tickle the baby's nose that he sneezes, and that sometimes also helps the nose to go open. And then things that we have said, sometimes when the baby has been separated from the mother, he might also be getting upset and not wanting to drink. So this should also be assessed properly, and then all the aspects should be discussed around separation, and if possible, it should be reduced and changes should be made if it is at all possible. And then also we have talked about the possibility of new soap or new deodorant or a new perfume that might also play a role in that the fact that the baby is not wanting to breastfeed anymore. Then our second big group of feeding difficulties or problems from the baby side is feeding difficulties due to baby colic in the breastfeeding baby. Yes, breastfeeding babies can get colic, and the symptoms of colic are very similar to the normal symptoms of colic, like namely abdominal discomfort, excessive flatus or winds, explosive stools, light green stools, and this is the whole problem can be ascribed to the fore milk, hind milk problem of breastfeeding, which we will discuss now in much more detail. We have, in the very first session that we have, and later on as well, we have talked about the fact that the hind milk is more fat rich, and that satisfies the baby for a longer period, while the fore milk has a much higher lactose content. Now, if the baby, for example, only gets lots of fore milk with lots of lactose, there's an enzyme called lactase in the baby's intestines that is responsible for the breakdown of lactose. And if there's an excess of lactose in the gut, there's not enough of this enzyme lactase, and that makes that the baby gets literally signs of lactose intolerance or lactase deficiency. And this causes this deficiency, or the fact that there's not enough lactase to break down the lactose, makes that there's an excess of lactose in the gut, and that these undigested lactose create an osmotic gradient that draws water into the bowel, and that causes distension of the gut, together with also gas that's been produced by this also excessive lactose, and that causes cramping, and that also causes the looser stools. The stools might be green in color because also of the presence of bile that has not been reabsorbed. Now, depending on the extent of this lactase deficiency and the quantity of lactose that's now not been digested, the symptoms can range from mild abdominal discomfort to really severe cramps and severe dehydrating diarrhea. So this is extremely important. And the solution, as we've said, is to improve attachment to the breast and to make sure that the baby gets hind milk by emptying first the first breast before he's been put over to the second breast. Then our third problem that we are going to discuss is tongue tie. And you can see it clearly here on the picture. The baby's tongue is literally being tied by this frenulum that is normally the frenulum is only on the back part of the tongue. In this case, the frenulum comes right to the point of the tip of the tongue. And what happens then is normally when the baby suckles on the breast, he puts his tongue over his lower gum and then that enables him to draw the breast deeply into his mouth. And now if the tongue is now literally too short and it doesn't reach the lower gum, the baby can't really draw or pull the nipple into his mouth, and that causes the fact that breastfeeding is just not working. The baby can't attach properly to the breast and obviously not suck properly. It might even be when the baby cries, like in this case, the tongue might even have a little bit of a heart shape because of this frenulum that is sitting here and being tied too much. Now, what happens, the way in which one can solve this problem is by what we call a frenulotomy, and this literally means is to cut this frenulum to almost kind of loosen the tongue so that the tongue can reach forward and the baby can curl his tongue around the nipple and push it to the roof of the mouth so that he can have a proper latch and can suckle properly. Our last problem is a cleft lip and a cleft palate. Now, a cleft lip alone without a cleft palate is not a problem, because the baby is not really using his lips and in breastfeeding to suckle. So there's nothing that really interferes with breastfeeding, because the palate is the most important thing, because it enables the baby to attach to the breast, and it creates that the tongue and it creates that the tongue presses the nipple against the hard palate, and this, as I'm saying, the lips don't play any role. So in the case of a cleft palate, then literally the baby's mouth, the cleft in the roof of the baby's mouth prevents that this vacuum can be established or formed, so that the baby can suckle the nipple into his deep enough into the mouth, and then also milk will be exuded from the nose. There will milk coming through the nose as it's going through the opening um, uh, uh, um, into the nose. Now, there's no reason why the mother should be discouraged to put the baby to the breast if she really wants to give breastfeeding, and the baby can just, for comfort and also for the pleasure of food, just suckles a little bit on the breast, but then the bulk of the baby's food, if I can call it like that, will then be given in expressed milk. And that I'm not going even trying to explain all the different ways in which the baby will get this expressed milk, because there is such a variety of measures, and as the technology and as the specialization in this area is growing, it develops all the time. So, and that's why it's really an area of specialization that I'm not going to go into much further. And that brings us to the end of lesson 4, and that brings us to the end of this session 4, and you have to complete the quiz, the final quiz, in order to be able to continue to the next session. Hope you've enjoyed it.